Good morning, everybody. My name is Akriti Soni, and I'm a PGY1 internal medicine resident at St. Vincent Hospital, Worcester, Massachusetts. And today I'll be talking about liver injury in view of rhabdomyolysis. Acute liver injury can be multifactorial. However, transaminases in levels more than thousands always raises alarms among healthcare workers. Evidence suggests that serum transaminases can be elevated in patients with rhabdomyolysis due to muscle release of these enzymes, and this can cause confusion with liver disease. A lot of times in patients with rhabdomyolysis, due to these elevated levels, there is additional workup of biochemistry, serology, molecular, and most of these turn out to be negative. And unnecessary liver tests like liver biopsy also reveal no abnormalities. As a corollary of over-investigating for liver disease, there may be a failure to recognize and investigate true muscle disease. So let me talk about our case, where a 74-year-old man presented to us after sustaining an unwitnessed and mechanical fall and lying in the rain for 5 hours. His physical exam showed unremarkable vitals, but multiple bruises on his torso, legs, and limited range of motion of his right shoulder, arms, and legs. The stroke protocol was followed and a cerebrovascular accident was ruled out. His labs reflected an intrarenal pattern of AKI with a creatinine of 2.25, and then the CK levels came back with alarmingly high levels of more than 40,000, consistent with rhabdomyolysis. Aggressive fluid resuscitation was initiated. Unfortunately, the patient became oliguric and developed hyperkalemia, necessitating dialysis. A day later, his AST and ALT levels skyrocketed, going up to more than thousands. And the patient became progressively thrombocytopenic, with levels dropping to less than 40,000. However, I would like to grab your attention and point to the fact that during this hospitalization, his bilirubin, INR, and ALP were all within normal limits. Viral hepatitis, tox screen, tick-borne disease, HIT, and DIC panel workups were negative. We noticed that with regular dialysis and supportive care, not only did the CK levels decline, but the AST and ALT also started returning to normal, as shown in the graphs below. And as the kidney function slowly improved, platelet levels also returned to normal. There are 4 major causes for transaminitis more than 1,000: viral, vascular insult, toxigenic, or autoimmune hepatitis. The viral panel in our patient came back negative. A ratio of ALT to LDH, as calculated by Cassidy and Reynolds, helps to rule out vascular causes. The ratio in our case was 7, which helped us rule out any other vascular causes. CPK, on the other hand, is a toxin that leads to AKI and has also been hypothesized to cause oxidative stress-induced liver injury. However, we need to realize that AST is a ubiquitous systolic and mitochondrial enzyme, also found in skeletal muscle, kidney, brain, and lungs. It is seen to be elevated in muscle injury, even in the absence of hepatic injury. Although more specific to the liver, ALT is also found in other organs, and though its rise in rhabdomyolysis is not as high as AST, it does show elevations. In most cases, like ours, normal bilirubin, ALP, and INR are better predictors of the synthetic function of liver. And though acceptable to rule out the aforementioned causes, we need to avoid invasive testing and instead monitor the AST and ALT levels, which usually decline as CK levels decline. Thank you.